In this video, we're going to cover the T-cell immunodeficiencies. If you want to understand basically how immunodeficiencies are recognized, diagnosed, the symptoms, and the populations that are affected by them, there is a separate video, the primary immunodeficiency overview video. That's where I cover kind of the background of all immunodeficiencies. In this case, we're only talking about immunodeficiencies that affect the T-cell compartment. So to do this, let's first do a quick overview on T-cell development. So T cells are basically an end stage developmental status, or an end development stage of the common lymphoid progenitor. The common lymphoid progenitor makes T cells, B cells, and NK cells. Basically, in this case, a common lymphoid progenitor is going to leave the bone marrow and travel all the way to the thymus, where they become pre-T cells. In the thymus, they're under the influence of thymic epithelial cells and thymic hormones, and the cells further differentiate through a series of stages into T cells, characterized by the development of the T cell receptor, the ability to proliferate in response to mitogens, and expression of cell surface antigens. And that's kind of what's being demonstrated here. So when they arrive in the thymus, they're kind of like a baby. They're bald. They're double negative. They don't express CD4 or CD8. They then go about rearranging their beta chain in the first DN2 and DN3 steps. Once they've done that, they create that beta chain and they pair it with a pre-T alpha surrogate receptor. As long as it works, it actually makes a huge leap here. It goes from being a double negative cell to a double positive cell. So on a flow plot with CD4 here and CD8 here, basically your trajectory is here's where you arrive in the thymus, then you move over here to double positive land, and then you have to make a decision after you've made your alpha chain. Are you going to become a CD4 positive cell, or are you going to become a CD8 positive cell? That's a strength-based signal. If you recognize self-MHC with moderate strength, you're going to become a CD4 positive cell and stop expression of CD8. If you recognize the self-MHC with kind of weak strength, you're going to become a CD8 single positive cell and stop expressing the CD4 molecule. And that way the decision is made. And that's done after rearrangement of the alpha chain. There are subpopulations of the CD4 compartment, namely the Th1s and Th2s. These aren't set in stone necessarily, but they are an indicator of the types of cytokines and the type of functions that the immune response that is made of these cell types will make. So for example, Th1, highly pro-inflammatory, helpful for viral infections, tumors, intracellular infections. Th2, this is your parasite bug, or parasite cell, or also it is important in mediating allergy responses. So what do we think about when we think cellular immunodeficiency? So literally, we can kind of think of cellular immunodeficiency the same way we think of advanced HIV. Really what we're looking for, though, is these same symptoms in very young patients who are not infected with the human immunodeficiency virus. These aren't acquired. These are genetic, okay? So basically, we're going to see patients with chronic intracellular infections. We're going to see a lot of wasting, diarrhea, and some graft versus host disease that may develop. These patients are especially susceptible to malignancies because remember, our T cell response does a lot to protect us against tumor antigens. They also can develop infections with fungi, particularly Candida, and then pneumocystis. Those are kind of your big deal ones. You also worry about them with mycobacterium infections. TB is a big deal. So basically anything you would worry about in the HIV/AIDS community, that's what you're going to worry about in these kiddos. There are instances where people have been given blood transfusions, marrow or thymus transplants, or even in utero, transplacentally from the mother. And basically what happens is that's where we get those graft versus host disease. The lymphocytes react against the host's allogeneic cells, and the host is unable to control them because the control mechanisms are lacking. All right, how are we going to find it? Well, first off, your screening tests, really easy. Total lymphocyte count. If you do some flow and you're not seeing the right amount of T cells, that's a bad sign. The other thing is a delayed type hypersensitivity reaction. This is essentially a type 4 hypersensitivity skin reaction. So what you do is you basically directly under the skin inject with either tetanus toxoid, if they've been immunized, PPD, Candida, any of these organisms that they probably would have seen and should have a memory response to. If they've been immunized, you can even use mumps viral antigen. Any of these things that they've been immunized to that they should have a memory T cell response to. So if I have a kid that I know I gave them the MMRV vaccine, right? Measles, mumps, rubella, varicella. I can take mumps antigen. I can inject it directly under the skin, right? And then within about 24 to 48 hours, I should see a wheal, right? Because those Th1 cells should start pumping out interferon gamma, which should lead to a nice big induration. If I don't see that, that means the T cells aren't functioning, okay? The other things you can do that are kind of considered definitive tests to determine T cell function include T cell quantitation, basically just enumerate them. In the blood, it should be somewhere between 65 to 80%, and really you're just looking for CD3 positive T cells because that gets you both your CD4s and CD8s. You can do response to mitogens, antigens, and allogeneic tests in vitro. They basically measure the ability of the patient's lymphocytes to proliferate when mixed with mitogens, something like PHA, concalabin A, pokeweed mitogen, antigens like Candida, or allogeneic lymphocytes. Basically, I take your cells and I mix them with my cells and they fight. And that leads to an immune response, okay? You can also look for T cell subpopulations. So you'd basically take monoclonal antibody reagents to T cell surface antigens to basically look for your CD4 to CD8 ratios to make sure that you have the normal 2-to-1 CD4 to CD8 population that you expect to see. Okay, so what are our main T cell deficiencies? The first is DiGeorge Anomaly. Dr. Jones talks about this extensively in her notes, so I won't go into it too much. This is basically a congenital disorder that results from arrested development of the 3rd and 4th pharyngeal pouches during the development, basically. So this happens at about 6 to 12 weeks of gestation. The result is basically absent thyroid, or absent thyroid, so you have, not thyroid, thymus. Absent thymus. I don't know why I wrote thyroid there. But it's basically thymic hypoplasia. You also do have hypoparathyroidism, but for the purposes of my video, the thymus is a little bit more important. You also see other anomalies of the aortic arch and abnormal facies. So you can see you have microcephaly, you have a low nasal bridge, minor ear anomalies, micronathia, you have this thin upper lip. So all of these things are kind of characteristic of a patient with DiGeorge anomaly. Diagnosis, you're going to see the whole gamut. So if they don't have a thymus, the T cells have nowhere to develop. So then therefore you have no T cells. So you have a low total T cell lymphocyte count. If the patient does not have a thymus at all, you will have 0 T cells. If they even have a little bit of a thymus, you'll have low total lymphocyte count. You'll have reduced T cell numbers, completely 0 if it's, completely absent. You'll have reduced to no response to mitogen. The B cell function is kind of variable. So think about this. If I have some thymus, I'll have some helper T cells, so I'll get some immunoglobulins. If I have no thymus, I'll have no T cell help, and that in a way could basically result in an IgM, like a hyper IgM response, right? You can also have T cell function without treatment improve over time in some patients and deteriorate in others. So the T cell function is somewhat variable in this, but we know that it's reduced from what it should be. Bare lymphocyte syndrome is the other one. Basically, remember that when the T cell is making its decision, should I become a CD4 positive T cell or a CD8 positive T cell, it's talking to an antigen presenting cell that is expressing the antigen on MHC class 2 or MHC class 1, depending, right? So this would be MHC2, and this is 1, right? Okay. In bare lymphocyte syndrome 1, there's no MHC class 1. So that means CD8 can't bind. That means we can't judge how strong CD8 is binding. So CD4 automatically wins. If MHC class 2 is missing, then the opposite happens. So you lack either CD4 or CD8, depending on the MHC. Thankfully, this one, super, super rare. It's really just not something that happens all that often. But when we see it, we see all the same symptoms that I mentioned before: the wasting, diarrhea, intracellular infections, increased risk to malignancies, things like that. These patients can also have fatal reactions to live vaccines. So this is one population where you definitely would think twice before vaccinating, which I almost never say. And this is very similar, particularly the MHC class 2 dysfunction is very similar to patients with advanced HIV.